Welcome to this podcast from Neurogastroenterology and Motility. It publishes original research and topical reviews on basic and clinical aspects of gastrointestinal sensation and motility, as well as brain-gut interactions.
So welcome everyone to this month's podcast from Neurogastroenterology and Motility. My name's Adam Farmer and I'm a gastroenterologist at the Wingate Institute in London. This month it's my great pleasure to welcome Dr. Daniel Kauff. Daniel is an assistant professor of surgery at the University of Mainz in Germany. So Daniel, many thanks for joining us on this month's podcast, and congratulations to you and your co-authors on your paper entitled Transcutaneous Sacral Nerve Stimulation for Intraoperative Verification of Internal Anal Sphincter Innervation. So Daniel, if I could start with this question, what are the current uses for pelvic intraoperative neuromonitoring, and how is it currently performed?
Thank you very much, Dr. Adam Farmer. First of all, I'm really happy to be here, and I'm very happy to answer your questions. To your first question, we use this pelvic intraoperative neuromonitoring technique in different kind of surgical procedures. First of all, you can use it in the field of urology. For instance, when you perform the prostatectomy and you have to spare the pelvic autonomic nerves. Moreover, you can use it in gynecology during hysterectomy and surgery for endometriosis, where it's very helpful. And finally, and this is the main part where we use it at the moment, is in colorectal surgery, and there we have the most experience with this method, especially in rectal cancer surgery. You can use it in open and laparoscopic or robotic surgery. We have data for that too. Finally, the method itself is used intraoperatively, intracorporal. That means when we do the dissection in the minor pelvis, and we are at the field where the pelvic autonomics run, we can do the neurostimulation with a bipolar microfork probe. And this probe is used during different steps of the surgical procedure, and there we can check the nerves and identify whether they are in function or not. Currently, we have different data on that, and it works quite well, but I will come to that later.
So does it predict outcomes in patients undergoing pelvic surgery?
Yeah, we have several studies where we demonstrated the potential for prediction of functional outcome. And I really want to point out the sexual function here, the urinary function, and the anorectal function, especially fecal continence. We have data on that. But what we are almost now finished with a new study. It's a multi-center randomized study, which is called NEUROS. And in this study, it's located in Germany. And in this study, we have randomized patients to those who undergo rectal cancer surgery with pelvic intraoperative neuromonitoring, and those who undergo the surgery without the neuromonitoring system. And the study is currently closed. It's finished, but now we are very happy and excited to evaluate the functional results in both therapy arms. We have a follow-up of 12 months in the study, and we will have the data very soon.
Yeah, that data sounds very interesting indeed. But what do you see as the weaknesses of the current techniques?
Yes, the weaknesses is, and this is something that's why we have performed the current study, which we will talk later on, is that it is used intracorporal. That means we can only use the technique once we are in the field where the pelvic autonomic nerves are at risk to be damaged. So this is some kind of, we desire to have a system which works more outside the operating area, or probably who is giving us more information before we do the dissection. This would be great in order to get to know other effects which might come from other therapies, such as radiotherapy, which is done in advance before we do cancer surgery in most cases.
So tell me a little bit then about transcutaneous sacral nerve stimulation.
Well, the transcutaneous sacral nerve stimulation itself came up by the idea when we performed sacral nerve stimulation in patients for fecal incontinence in our clinic. And we wondered what is happening, because normally we look at the somatic innervation when we perform the sacral nerve stimulation, and we wondered what is happening to autonomic nerve innervation. And in this case, we used the pelvic intraoperative neuromonitoring system, the device itself, which is based on electromyography of the internal anal sphincter, and we looked at what is happening to the patients intraoperatively when we do use it for sacral nerve stimulation. And interestingly, we could show that the autonomic innervation is affected by the sacral nerve stimulation. Then we thought maybe, well, why not using transcutaneous sacral nerve stimulation, which is performed outside the operating area on the sacral foramina. Why not using this technique for pelvic neuromonitoring? And then we funded. We got we got lucky to be funded by the Federal Ministry of Education and Research here in Germany. And we had two great partners in this project: the Inomed company and the Fraunhofer Institute for Biomedical Engineering here in Germany. And then we developed this experimental study for transcutaneous sacral nerve stimulation, which is working outside the operating area and gives us results on the pelvic autonomic nerves.
So what
function.
What methods did you use in your study?
Well, in this first step, we performed an experimental study, which means we went into the operating theater, an experimental operating theater with pigs, and used arrays of electrodes, cathodes, which were developed by the Fraunhofer Institute for Biomedical Engineering, and we placed those over the sacral foramina even before we have done surgery. And in order to influence the currents which were produced, we applied several anodes on the back, right, and left thigh, and lower abdomen, and even intraanally intraanally. And then we did stimulations using this novel technique and the standard technique, which I have already described, and looked and observed the electromyographic signals of the internal anal sphincter in different steps of the experiment.
So what were your key results from your study?
Well, in this study, we could show that transcutaneous stimulation-induced increases of the internal anal sphincter activity could be observed in each animal, which was a big or great step for us, because we never thought that this would be possible. But we had to do a lot of tests in order to get the results. We have done 300 test configurations of cathode-anode applications, and out of those, only 18 exhibited the change in the internal anal sphincter activity, which correlated with preserved function, pelvic autonomic function. And finally, when we performed the nerve lesions at the end of the experiment, we could also show that in these specific electrode configurations, the function was not there was a dysfunction. The pelvic autonomic nerves were damaged, which showed that this method is valid. But still, you need specific electrode configurations, and only those work. All others did not work. So this is this is the challenge of this novel method when we want to implement it easy, practical.
So what were the limitations of your study?
Well, the study is limited to experimental results in a small series. Nevertheless, the data collection could be performed in a standardized setup. The next step would be to investigate whether this novel approach could be translated into humans for non-invasive pelvic intraoperative neuromonitoring. However, this requires a considerable variety of standardized electrode configurations and amount of test simulations, which may hamper its practical use.
So how do your results now take the wider field forward?
Well, in conclusion, the study successfully demonstrated the feasibility of transcutaneous sacral nerve stimulation for the verification of internal anal sphincter innervation under selective electrode configurations. If a reliable online signal analysis could be implemented, this approach may be of clinical value for the development of a more minimally invasive pelvic intraoperative neuromonitoring. This could enable early assessment of functional autonomic nerve integrity even before we perform the pelvic dissection, and may possibly reduce the necessity of intermittent direct nerve stimulation by the operating surgeon. Moreover, the technique could be useful in the field of sacral nerve stimulation for diagnostic and therapeutic purposes, as well as further neurophysiological investigations based on simultaneous observation of the somatic and autonomic nervous system.
So, Daniel, with that, I'd like to thank you and your co-authors for an excellent paper, and as well as assisting in this month's podcast. I'd also like to thank our listeners for tuning in, and look forward to welcoming everyone to another instalment next month.
Further information about this paper can be found on the journal website. We hope that you have enjoyed this podcast, and we look forward to welcoming you to next month's edition.